Thank you, madam. Thank you for your kind words. I always feel very privileged that when madam is chairing this session. Thanks, Kamal, for giving me talk. It's a debate. We are three of us are here.
I think I'll have to, excuse me, I'll just read.
Oh, yes, sure, please. I'm sorry for that.
So here, 55 kilo Indian male on optimal cardiac medication has diabetes with an A1C of 8.2 and with a BMI of 25.5. Indian should have a BMI of 23. This gentleman is 25.5. The LVEF is 45% and on echo, and he has a history of CABG 2 years ago. He is on which should be the best SGLT2 inhibitor. So we have three speakers. One is going to speak on dapagliflozin, the other one on EMPA, and the third one on Remo. So we have to choose between the three. Over to Dr.
Thank you, Chairperson. I will request AV guy again to make it again 10 minutes because it's already 50 seconds gone. Thank you. So, thanks, Chairperson. Thanks, moderators. Thank you, Kamal, for giving me an opportunity. Thanks to the scientific committee. So we are three who are going to talk on DAPA, EMPA, and Remo. I don't know whether Remo will be really in the debates. I doubt. So I'm sorry, Jesh, why they've been given to you. EMPA, yes. Many kings are going to Sanjeev Pathak only. All Ahmedabadis king go to only Sanjeev, so he can afford to write EMPA. But I will show the scientific evidence. We will not talk anything related to the other than science. The commerce will not come here. But yes, it is. Commerce is there because this is supported by AstraZeneca. DAPA is a preferred SGLT2 in treatment of heart failure. And again, Dr. Raghu had talked about the case. So please, the case is very important with a BMI of 25.5, having a history of CABG 2 years back with ejection fraction of 45%. This patient is having A1C of 8.2. The further investigations required or information required, definitely we would like to know about the eGFR, and I'm sure eGFR is normal. Is this patient is with improved ejection fraction? Now that's very important because this is not the history of 45% ejection fraction. I don't know whether previously patient was with a 30 ejection fraction and now he had come with a 45, or whether patient was 55 ejection fraction and gone down to 45. Is the patient is hospitalized? I mean, patient is asymptomatic and he was already in hospital, where patient is being asked by me that whether I should start the treatment or not. So I don't know whether patient is hospitalized or not, and I don't know whether it is ambulatory, no symptoms. So these are the some of the things which I don't know, and I believe that patient is ambulatory, patient is having a stable ejection fraction, and eGFR is normal. So my further talk will be depending on that information. The European Society of Cardiologists, the diagnostic criteria for heart failure is the reduced ejection fraction is less than 40. That's important. With a moderate reduced ejection fraction is between 41 to 49, and with preserved ejection fraction is more than 50%. I'm sure all of you know about that. This is the European Society of Cardiology diagnostic criteria for heart failure category, and my patients come with this particular group with a moderate reduced ejection fraction between 41 to 49. We know that a patient may go between moderate reduced ejection fraction to preserved ejection fraction or to reduced ejection fraction depending on the comorbid condition. If a patient with diabetes, ischemic heart disease, high pro-BNP, lack of heart failure specialist is not going to a particular specialist, there is a possibility a patient with 45 ejection fraction might be going in 25 too. For those who are young age, female are more chances of getting improvement, lower heart failure severity, shorter duration of heart failure, and fewer comorbidities. Probably a patient with moderate ejection fraction may go to the preserved ejection fraction too. What's the guideline is talking about? This is 2022 American Heart Association, which is supported by ACC and all other associations in all over the world. The stage A, those who are at the risk of heart failure, and just before somebody was talking about the acute heart failure, what GDMT is, guideline directed medical therapy, is talking that SGLT2 is the class 1. If somebody is a pre-heart failure condition, again SGLT2 inhibitor is there. In stage C and D with a ejection fraction of less than 40%, even it is between 41 to 49 and more than 50, these are the two conditions where it is class 2A indication, while otherwise when it is a reduced ejection fraction less than 40%, it is definitely with SGLT2. But my patient is with 45, with SGLT2 inhibitor goes with class 2A along with other therapies of heart failure. The same guideline is talking when it's a symptomatic, definitely again the SGLT2 inhibitor, even when the patient ejection fraction is between 41 to 49. That is what 2A. And the level of evidence with this, we have randomized control as well as non-randomized control. Both have 2 and 2B evidence for the patients who should be on SGLT2 inhibitor. Now, this is very clear, and I am sure since last so many years, we all know that SGLT2 inhibitor should be given with a patient with established cardiovascular disease. And after the heart failure trial, it has been proved that SGLT2 inhibitor should be given irrespective of diabetes. They should be given all the patients with heart failure with preserved ejection fraction. Also, now there are data. Now here the debate is which SGLT2 inhibitor. And again, I'm sorry that I'm not putting here Remo. I'm putting directly DAPA versus EMPA because of the evidence what we have. The DELIVER, the largest, broadest trial to date in patients with LV ejection fraction of more than 40%. This is the recently published trial in 2022. The DELIVER having the number of patients was 6,263. Randomized DAPA 10 versus placebo, median follow-up of 2.3 years. The primary endpoint was composite of CV death, worsening heart failure, full patient population, and patient ejection fraction was less than 60%. And the baseline characteristic was around 54%. Average LVEF with 50% of the patients were less than 60 ml of eGFR, and 10% of the patient hospitalized or recently discharged. There are other secondary endpoints which include CV death and all-cause mortality. Now, primary endpoint, there is a 18% relative risk reduction. That's very important. DAPA significantly reduced the risk of CV death or worsening in patients with LV ejection fraction of more than 40%. And again, as I told you, that my patient having ejection fraction of 45%, and you can see the difference from the day 1, and NNT is 32. So DAPA 10 versus placebo, the composite CV death or worsening heart failure was significantly reduced by 18% relative risk reduction. If you see the primary endpoint in full population with LV ejection fraction of less than 60, again my patient goes in that because its ejection fraction is 45%, the HR is 0.8, and you can see very significant p-value of 0.0008. The LV ejection fraction of less than 60%, again further the HR is 0.83 with p-value is 0.009, which is again very significant. So dual primary analysis. The outcome of LV ejection fraction of less than 60 or even with more than 60. Now here I am putting the patient because we don't know that this patient had gone from 65 to 45. So even at any level, you put the patient with our preserved ejection fraction or with the patients who are moderately preserved ejection fraction, both the condition, the primary composite, you can see here all three, the patient with ejection fraction of less than 60, more than 60, all of them are getting benefit for worsening heart failure event, hospitalization for heart failure, CV death and all-cause death, all of them got benefit. The primary endpoint in a pre-specified subgroups, again I am putting the LV ejection fraction between 40 to 49 and even more than 60 also. They also get the benefit. Enrolled during your within 60 days, within 30 days of hospitalization of heart failure. Again, there was a benefit. Yes, it was more an improved ejection fraction patient with an ejection fraction of less than 40. They improved. They also got the benefit, the favoring the dapagliflozin in this particular trial. If you put the secondary endpoint, which is KCCQ total symptom score, and you can see here there was a significant benefit with the patients who are put on a DAPA in compared to the placebo, whether you go with a 5+ improvement, 10+ improvement or 15+ improvement. Now let us look at EMPA data because this is a debate and I have to show EMPA data with Sanjeev Bhai is going to show you more. This is the Emperor Preserved trial and study design, which is a phase 3. He will be talking more about it. The LV ejection fraction of these patients was more than 40. Effect of EMPA versus placebo, primary and secondary outcome. Please just see this, and I am going to show you the pool data only. The results of key endpoints in the subgroup of the patient with preserved ejection fraction. Yes, there was a benefit. SGLT2 inhibitor is going to have the benefit. The same may be shown by the Remo also, but I have to show the data between DAPA and EMPA. And here I am going to show what the pooled analysis suggests. The Emperor Preserved, when I am comparing directly with DAPA heart failure and DELIVER, if I combine both, it is more than 11,000 patients with heart failure with moderately reduced ejection fraction. And you can see in DAPA heart failure, there was a 14% relative risk reduction of the patients who have moderate ejection fraction. CV death, all-cause mortality, first heart failure, total hospitalization for heart failure. And if I put Emperor pool data, ejection fraction, influence the effect of EMPA on a heart failure and renal outcome, you will find the patients between 40 to 50, 50 to 60 and 60 to above. And the similar way the renal outcome, the Emperor reduced and Emperor preserved. Effect of EMPA, time to cardiovascular death, it is Emperor preserved was 0.9. So no benefit of CV death with EMPA even in a pool analysis if I put the Emperor reduced and Emperor preserved both the data together. What about patient future risk? There is always a possibility this patient may go in hospitalization for heart failure. For CKD is already with the 45% ejection fraction. Post CABG diabetic patient who is uncontrolled. So there I have to see the data with the what about the CKD status, how it is going to show the benefit, the molecule which we are going to write to this patient, whether it is going to halt the progression of CKD status. Also, here the data for a DAPA CKD, which is also talking the patient who are started on DAPA, there is a 44% relative risk reduction in composite outcome of sustained decrease in more than 50% of eGFR decline, end-stage kidney disease, and with renal death. So if I put that EMPA kidney reinforce the SGLT2, yes, there is a EMPA kidney outcome. Also the primary endpoint both, but all-cause death and composite CV death for hospitalization for heart failure was not there in EMPA kidney. It was only with DAPA CKD2. So last slide, the DAPA is ahead of EMPA in various parameters. The clinical parameter, glycemic control, almost same. But the new onset of diabetes was relative risk reduction by DAPA. All-cause mortality in CKD and CV death and hospitalization for heart failure in CKD, again beneficial with DAPA, and hospitalization for heart failure in primary prevention and CV death in a reduced ejection fraction was also significantly reduced, which was not studied even with the EMPA2. So with this, I put the case that yes, still you can use any SGLT2 inhibitor, but the data which is shown in the benefit with the DAPA heart failure, with deliver, and with DAPA CKD, with this patient with a 45 to 45% of ejection fraction, it goes more in the favor of the molecule which have more scientific evidence in compared to EMPA. Thank you very much.
Good afternoon and thank you, Dr. Kamal, Cardiocon, and the organizers, and thank you, Bansi. One of the slides, not one, a couple of your slides on the bottom showed that dapagliflozin is not approved for preserved and mildly reduced ejection fraction. Of course, it is, but that was your slide. And Bansi, being the strongest lawyer for the SGLT2 inhibitors like Ram Jethmalani, but I have got the strongest candidate, that is Amitabh Bachchan or empagliflozin. So he fought for Vinod Khanna. I am reminded of the 1970s and 80s when the Amitabh Bachchan Vinod Khanna war was getting on, and then suddenly Mithun Chakrabarti came, poor man's Amitabh Bachchan, remogliflozin. So I know that Ram Jethmalani is there against me, Sorabji is there against me, the two biggest lawyers of our country, and I am a very small lawyer compared to them, but I am going to speak in favor of Amitabh Bachchan, that is empagliflozin, the Amitabh Bachchan of SGLT2. Let us start with this case. So first, I have a heartfelt sympathy because they are fighting for a losing cause. The 55-year-old gentleman, he is obese because his BMI is 25, though he is 55. So he must be short. He is having uncontrolled diabetes. He has past history of CABG. His ejection fraction is mid-range, 45%. He is on GDMT and lifestyle, which SGLT2 obviously empagliflozin. Why? What are our aims of management? First, of course, glycemic control. He has come to a diabetologist. Second, maybe he is overweight, BMI is 25 plus, so some weight loss. Prevent future cardiovascular events. He already is having cardiovascular event. He had ASCVD and has undergone CABG. To prevent heart failure progression and to reduce mortality. Now let us talk about the glycemic control. Bansi never showed any glycemic control. He deliberately omitted diabetes. He put diabetes out of equation as if the patient is not diabetic. We know that dapagliflozin's data, like the heart failure data or CKD data, is regardless of diabetes. In diabetes, dapagliflozin has mainly principally one trial, that is DECLARE-TIMI, and it is a negative trial, we all know, as far as the cardiovascular 3-point MACE is concerned or cardiovascular death is concerned. What about glycemic efficacy? I could find only one trial which compared EMPA versus DAPA, and it clearly showed that HbA1c, fasting, weight, systolic blood pressure, everything was better with EMPA compared to DEPA. Comparing EMPA and REMO, there is no trial, but comparing DEPA and REMO, there was an Indian trial submitted for DCGI, and which showed that DEPA and REMO are equally effective. REMO is non-inferior, which proves that EMPA is definitely superior as far as efficacy is concerned compared to DEPA and remogliflozin. Now coming on to the cardiovascular events, we know that EMPA-REG is the benchmark or the most important trial which changed the way we treat type 2 diabetes. We don't treat just from the glucose numbers. We treat to prevent the cardiovascular events, and in this trial, very robust cardiovascular death benefit was observed, and it is an unbiased totally observation which all of us know. And this was regarding all the categories of cardiovascular death, whether the death from fatal MI, fatal stroke, heart failure related death, sudden death, everything was prevented, and that was also regardless of what type of CAD the patient was having. In this patient, we have priority to CABG and prior heart failure, LV ejection fraction being 45%. And in both these conditions, EMPA has clearly shown the benefit. We know the cardiovascular outcomes of all the cardiovascular, the SGLT2 inhibitors, and EMPA is the only drug which has shown 3-point MACE benefit, 4-point MACE benefit, CV death benefit, heart failure benefit in diabetic patient. Right now, we are talking about our patient who is having diabetes. He is not without diabetes. And the comparison is very, very clear. 3P MACE, CV death, all-cause death, significantly reduced with EMPA, nothing, no benefit with dapagliflozin. And that is why EMPA became the only SGLT inhibitor to be officially recommended to reduce the risk of death in diabetic patients with established cardiovascular disease. How about our Indian or Asian patient? You can see that the Asian patients actually benefit more. This data from the EMPA-REG clearly showed that the benefit was more compared to the other population. And if the BMI is less than 30, again the benefit is more. Our patient is having BMI of less than 30. So in both these conditions, the benefit of empagliflozin is very, very proven. So that is why this is the first drug that is approved. Now let us talk outside the EMPA-REG, and this is the analysis of 7 phase 3 big studies, and which also showed that 4-point MACE, 3-point MACE, CV death, heart failure, everything is positively influenced by empagliflozin. How about heart failure? Bansi mainly talked about heart failure. He forgot or deliberately forgot diabetes. And in heart failure also, EMPEROR reduced, EMPEROR preserved. All these trials have shown very good reduction in the heart failure hospitalization and composite CV death. Why DEPA showed more benefit? The probable reason was that the DEPA treated patients were not treated to the guideline directed medical therapy. Only about 10% patients were on ARNI, only about 7% patients were on CRTUs, only about 26% were on ICDUs, whereas in EMPEROR reduced, many more patients were treated with the more aggressive or the current therapies, and that is why the benefit observed was on top of that was less than what was seen in the DEPA-HF trial. Otherwise, there is hardly any reason to compare these two trials. But in the nutshell, I would say that in the declared TIMI and in the EMPA-REG outcome, it is very clear that the first hospitalization for heart failure in patients with myocardial infarction or cardiovascular events is very, very significantly benefited with empagliflozin and not with dapagliflozin. Both reduced and preserved ejection fraction, EMPA has shown benefit. Both in mid-range ejection fraction and preserved ejection fraction, the empagliflozin EMPEROR studies have shown benefit. So this is regardless of the ejection fraction, this is regardless of presence or absence of diabetes, but we are right now talking about diabetic patient where the benefit is definitely seen only with empagliflozin. The other benefits again are there with the other gliflozins also, but not proven to that extent, like the kidney composite outcomes, the effect on the blood pressure, the effect on the obstructive sleep apnea. All this may be there in this obese patient who may be centrally obese because his BMI is 25. He is a short person because at weight of 55. So he might be having the other comorbidities which may be benefited more with empagliflozin because EMPA has stronger data. Even in the NFLD, EMPA has stronger data compared to dapagliflozin. He was talking about the cost. Well, when you are choosing Vinod Khanna, he will be available at a lower cost. Vindhu Chakravarti at much lower cost. Empagliflozin slightly more expensive, but if you compare the cost, there is hardly any difference. And we Indians are very innovative. We doctors are no exception. The cost of therapy can be made half with half dose of empagliflozin. You just cut the tablet. And even the half dose will deliver you very good benefit as far as the A1C reduction is concerned or cardiovascular benefit is concerned. Emprise, Empareg, Emperor Preserved are all with 10 and 25 milligram. That is why the benefit of EMPA is there with both 10 and 25, which is not there with dapagliflozin. So to compare in a slide, EMPA, DEPA and REMO, I'll just finish. You can see that there are more pluses on EMPA side, whether it is glycemic control, weight loss, cardiovascular events, benefit in diabetic patients, reducing the mortality, heart failure may be equal, sleep apnea, the selectivity towards the SGLT1, SGLT2, 2500 times with EMPA compared to DEPA. So mechanistically also there is a great difference. And there is no negative thing to that. DEPA initially was rejected by FDA for the reasons we know. Moreover, there was initially warning of kidney injury, bladder cancer. EMPA has not shown any such warning. So safest. So I'll show you, I have got three medicines. One is remogliflozin, which is cheap, but does not have any cardiovascular, any renal benefit. Maybe there, but at present nothing is known. Second is DEPA, which is good for heart failure. It is good for diabetes, but diabetes plus cardiovascular disease, probably not, because the only trial which we have has not shown any cardiovascular benefit. And the third drug is EMPA, which is 10 rupees more costlier than the DEPA and REMO, but has significant cardiovascular benefit, significant death benefit. So which drug you will choose? Obviously, the patient would not mind spending 10 rupees more. Spending somewhat more for Amitabh Bachchan, definitely the directors would say more affordable than spending less with the other actors. So where is the competition? Is there any comparison? EMPA is a clear winner. Thank you very much for your very kind order.
Good noon, madam, and all the chairperson and my friends and those who are on the attending this CM. I would like to thank the Kamal and organizing the opportunity. I want to all the diabetologists are sitting here. I am the cardiologist talking on this topic because of Kamal, and he has given a topic like that. I have to fight. So of course, the Bansi has rightly told, and Dr. Phatak has also rightly told, but they have not shown one slide the conflict of interest. Both are studying the molecule of mind, and they are taking beer ahead. One thing is that I'm like underage, those who are getting the MBBS admission, but they cannot attend the college. So I'm like a tortoise in between these two rabbits. So I'm just starting my first step ahead. And of course, I want to say that I'm a human being living in the same world where the American and European are living. So I will try that I'm also a human being. And probably and Dr. Bansi and Dr. Phatak after 5 years will going to talk on remogliflozin, because this molecule will be on the lower side, and this might be growing one. Of course, Kamal has given me one thing in the diabetic population. So that's the one thing, so I can talk on remogliflozin somewhat. So we know that India is a diabetes capital and all these things, and these are the mechanism I don't want to discuss. And these are the SGLT2. These are, everyone agree that it's a class effect. So when we discuss the EMPA, CANA, no one has talked CANA. CANA has also got a good data. So why CANA was not here? So it's a class effect, like of course sotagliflozin, ertugliflozin, and people say SGLT2 inhibitor. So some molecule will require data for this one. So this is the Asian, I think Japanese molecule, and started studying in taken over by Indian company, and they have started this. So SGLT2 inhibitors are now recommended for almost all the indications for diabetic, non-diabetic, heart failure, kidney protection and all. So these are some of the study. Of course, Remo is not like they have not got any study. They have got a phase 3 study, and of course this is all Indian data, I can say, and they have studied the randomized blind control, and they have compared with a molecule. Of course, it is very difficult. We have not seen any atorvastatin, rosuvastatin hard endpoint data. So it is very difficult to compare all this. Even we have not seen head-to-head comparison between EMPA, CANA and DEPA. All our data, they are individual compared with the other placebo arm. So there is no head-to-head comparison. So I cannot compare Remo with DEPA and all this. But the Indian company, they tried to compare with a DEPA also and CANA also, and they have tried to collect the data. And these are our Indian doctors, they have studied Whether we believe or not, that we have to decide. So it's a double-blind study. The comparative arm of DEPA 10 milligram versus Remo, around 900 patients has been studied. 58 sites were studied, and of course we cannot compare, as we know that atorvastatin and rosuvastatin, we have got only comparative efficacy. So they have tried to do the comparative efficacy, because for hard endpoint reduction we require a very good study with so many patients, and that is a problem in our country, that almost we know that. So here they have tried to compare the molecule efficacy, compare with a DEPA and of course CANA and all that I am going to show. So here they have shown with a DEPA also the HbA1c level and week 24 and week after fasting. Of course, this molecule, one should not forget, Remo is to be given twice a day. So twice a day is advantageous. Why? That also I am going to discuss. So they have studied the postprandial. We Indians, we are facing more of the postprandial hyperglycemia because of our high carbohydrate meal. Another study, and they have shown the comparative efficacy between versus DEPA versus Remo. The INSPIRE study also, that's the Indian study, and that is assessment of safety and effectiveness of this molecule, and this was around 37,000 patients were studied, and 3-month data was completed, and they have showed HbA1c, fasting glucose, postprandial glucose reduction that was much more with remogliflozin, and the same kind of SGLT2 inhibitor effect like body weight, systolic blood pressure, diastolic blood pressure, and everything. Another study was done, the FOREVER study, that was compared between the remogliflozin and Vilda, compared with the established molecule like EMPA with a LINA. So that kind of combination was they have studied in around, of course this is a small study, around 180 patients. Indian patients were studied in 58 sites across the India, and it has shown the same efficacy and same adverse effect with this molecule. Another study was done in the glycemic variability study. Of course, this is around 75 patient study, but it has shown that why it was done. So it's a START study, based on a START study, where I think Bansi and so many were of this START study. Indian patient, they are consuming more carbohydrates. Even the patient is a diabetic or the non-diabetic. And this group of patients, they have got a more postprandial hyperglycemia. So that what we are not talking on this podium. So the dietary habits of type 2 diabetes, that what I have told, non-diabetic, diabetic, we are consuming more carbohydrates. That's a problem in our country. So here they have studied the glycemic variability, and they have applied a patch, and they have, this patient were given, the one arm was Remo, one was DEPA, and 2 phase, day 1 to 14 and 36 to 49. And what they have found that compared to the DEPA and Remo, the Remo has got a good effect on postprandial high glucose level. So what they have studied, and they have concluded that the more reduction seen in Remo compared to the DEPA, especially at the night time. So twice a day doses of remogliflozin compared to all other SGLT2 inhibitors, which are once a day, it is efficacious to reduce such kind of peak in sugar level. So this is one of the advantages of remogliflozin, and that probably will be a weapon to fight against this DEPA and empagliflozin. So it has shown that, of course, almost the same efficacy in HbA1c and all, but postprandial hyperglycemia, that was prevented by this remogliflozin, and that is advantageous for our Indian patient. This is a Revolution study, that interim analysis, where I think Dr. Bansi and Dr. Patak both have enrolled the patient in this study. So Revolution was also studied. This is also ongoing study, 365 patients, and it has shown that almost some part has been completed, and it has shown that Remo 100 milligram, Remo plus metformin 500, and Remo 500 plus 1000, it has shown efficacy for reducing the HbA1c, fasting, and all postprandial sugar level. Of course, with 500 milligram is also 500 plus 100 is good efficacious dose they have shown. And adverse event are at par with DEPA and all, what we can say. Another study has been done, that a comparative study of efficacy and safety of different SGLT2, and this is also EMPA, DEPA, CANA, and all they have compared, and they have shown efficacy for systolic blood pressure, diastolic blood pressure, and all these things, and it was found to be almost comparative to the other molecule. So these are some of the data they have tried to collect it, FOREVER, INSPIRE, Revolution, and phase 3 and GV study, and they have shown that this molecule as efficacious. Of course, I have told that to her hard endpoint like diabetic, non-diabetic, kidney patients and heart failure patients, preserved ejection fraction, acute MI, but they are aid. They are American and they are like that. We are Indian, so we are behind, but probably we will win in the future also. So I want to tell that among all oral anti-diabetic drug, SGLT2 has an advantage. Of course, it has some pleiotropic effect that is to be proven by this molecule, and it is demonstrated the safety and efficacy compared to the other glipizin also requires more data, but the Indians, they have got a higher postprandial glucose level, so that is one of the advantages of the remo. And of course, some of the negative points I have told that, and clinical evidence limited to Indian patients. Whether the company wants to try the global study, I'm not sure. Probably Dr. Bansi and Phatak will highlight this topic. A limited study on larger and heterogeneous group of patients will be required with this molecule, and probably head-to-head comparison is very difficult, but limited data, I can see that this molecule is not bad. Thank you. Thank you so much.